Welcome back. I hope you enjoyed a great lunch. Before we start with the afternoon, a quick information. The cups you use for drinking, please do not throw them away. We reuse them, we bring them back to the company. So there are boxes where you can put them after you've used them. Thank you very much. So now we change the sound. We go up a little bit higher from the abdomen to the thorax. Our next lecturer, he's from Slovenia. He is an emergency physician and he works in a department of physiology and emergency medicine. He will talk about the symptom dyspnea. May I present Dr. Gregor Prosen.
Thank you very much. Thank you for your nice introduction. Let's start with a little bit different lecture and session. You had lunch now, right? So if I lecture for 1 hour, this is sure to induce general anesthesia. So we'll make it much more interactive. You agree? I guess you already have some materials that you read and reviewed before, right? So you know a little bit, right? Who has read the pre-reading materials? Hands up. Okay, 3, good. How many of you are third year students? Okay, 4, 5, 6? Well, so 4 and 5 mostly? Good. How many of you have seen patient that is severely dyspneic, that is short of breath? Good. How do you think this patient felt? Anxious, yeah. Bad. Did you feel like you want to help them? Yeah, well, I'm a lucky man. I do that for my job, and I get paid for that, okay? So, from the perspective of an emergency physician, I work in emergency department and pre-hospital, half-half, roughly. I will present you how we use this absolutely revolutionary new tool. I mean, it's not new anymore, but let's say it's new. In dealing in addressing the patient with dyspnea, either objective tachypnea or just subjective feeling of dyspnea. I will switch between Mentimeter. Do you know the Mentimeter platform? It's a voting platform, nothing special, and the keynote slides, okay? I believe we have until 2 o'clock. Okay, so we'll make best use of that time. All right. Very clearly, I would like you to understand how we work up the patient, what would be the causes, and what, of course, would be major sonographic patterns of causes of dyspneic pathology. Okay? In 1 hour, I think we can handle that. But most importantly, I want you to understand, okay? Something that you will remember today, tomorrow is no word, but I want you to really understand. You have the machines, you will go to workshops, maybe in clinics you will also use the machines. I want you to build up on this basic knowledge in your clinical career. Because whatever type of doctor, specialist you will be, ophthalmologist, okay, maybe not psychiatrist, but ophthalmologist, internal medicine, surgery, any somatic diseases or symptoms or systems, most probably you will see this patient. We want you to be able to confidently react to these patients and make best use of technology. Okay, bring out your devices. You have 2 minutes, And just jot down. You can abbreviate it. You can make it shorter, longer, I don't care. What do you think are major causes of dyspnea? By this, I mean acute dyspnea, not 3 years long dyspnea. Acute dyspnea since yesterday, today, last week. Wow. That's quick. Maybe for those of you, put more differentials. Put them 2, 3, 4, 5. You don't have to only shoot one. You can shoot more, okay? For those of you who have voted, doesn't matter. But for those who can see, yeah, very good. So I think we already see the pattern. Pulmonary embolism, pneumonia, MCI, myocardial infarction. That is what it is. MCI. Yeah, okay, pulmonary embolism probably. Asthma, COPD, pseudocroup, okay. Pneumothorax. PAE is probably. Aha, okay, pulmonary embolism, pulmonary thromboembolism. Tension pneumothorax, pulmonary embolism, pneumonia, COPD, asthma, lung edema, RDS, trauma, heart failure exacerbation, COPD, pneumonia, asthma, myocardial infarction, heart failure. You know what? Anaphylaxis, aspiration, partial lung emboli. Ooh, good one. MI, anaphylaxia. Good. You know what? This is all the causes that I know, really. You taught me even some more. So, yeah, that's very good. I agree. All of the causes up here are legitimate causes of dyspnea. Subglottic edema, sure. Anemia, true. Allergic reaction, very good. Okay, next question. Now, of these causes, as I said, put 3, 4, 5, 6. Which do you think we can see, identify by lung ultrasound? So that were all possible causes, and you did it very well. Now, what do you think, which of these can be seen directly by ultrasound? There are no wrong answers, okay? Because if it is wrong, no one will know, but at least I can give you feedback why it would be wrong. I said put as many as you know. 2 minutes.
I think you have to open the voting again.
Do I have to?
Oh, open, yeah.
Okay, so pulmonary embolism. Do I have one volunteer? One volunteer to write on the table. Can I ask one to just write down? Yeah, come. Hi, what's your name? Vanessa, please. Can you put down, it's okay, thank you. Or if you want to help, you can also come. Yeah, you want to help? No? Okay. Vanessa, so put down, do you agree we can see pneumothorax? Yeah, we agree? Heart failure, pneumonia, pneumothorax, hematothorax, emphysema. Come. What's your name? What's your name? Come, Catherine. You also jot it down. Okay. Aspiration. You write down aspiration, emphysema, pneumothorax, pneumonia, pulmonary edema, lung edema, pneumothorax, lung emboli, okay, heart attack, PE, pleural gas, pneumothorax probably, lung edema, okay, heart failure, edema, pericardial tamponade, very good one. Emphysema, okay. Good. Pneumothorax, heart failure, Catherine, can you put down subglottic edema? Bolus, you mean like aspiration? Bolus aspiration? Yeah? Okay. Catherine, bolus. Emphysema, pneumothorax, edema. Okay, I think that's it. All right, good. Very good. Please, thank you, ladies. Please remember this. We'll come back to it later. Okay. Now, I need a gentleman for demonstration. Whom I can get? Anyone? Yeah? Come. Okay. Did you see videos? Which probe they take? Can you lay down? Did you see the videos? Yeah? Did you see where we put the probes? Okay, we'll go that through together and we'll see what happens when we use the ultrasound. Can they see the screen? Yes. Ah, okay, very good. Very good. Okay. You know that we use different probes in ultrasound, right? How is this one called? This one? Cardiac. Phased array. This one? Linear or vascular. Nerve blocks also. And this one? Curved. Abdominal. Yeah? Which one do you think we will use? What's your name?
Malte. Malte.
Malten. Which one you think we'll use on Maltin to see his lungs? What would you suggest? Which one? Linear, yeah, okay. Any other suggestion? Maybe cardiac, maybe abdominal? Okay, let's use linear and see what happens. Okay, it won't explode. Oh, it's up there. Very good. Okay, can you come a little bit just down? Yeah, so put your shirt up a little bit. And we'll use linear, I guess, this one. Okay. I'm sure you have seen this in the previewing, but I'm taking linear probe, and I will put it exactly on the most gravitationally top position of his chest. Okay? Let's see what happens. I will put it on the right side, not to interfere with heart on the left.
I think you have to use the probe. It's
Which one? Pop, 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 pop. I thought I... All right. Just one moment. I'm not familiar with this one, but let me see if I can find out. Okay, that makes sense. Okay. Now, I have put the linear probe longitudinal, which is actually, can you step up? Which is actually transverse to his intercostal space. Agree? And we put the probe on. What do we see? Would anyone want to describe this image?
We don't have the image.
Oh, we don't have the image? Oh, yeah.
No.
Yeah, good. I will just... Okay. Can someone, let's see how this works. Can you describe what you were seeing? Describe it in terms of black, white line, black rib, shadow. Just describe it to me, please. There are no wrong answers. Describe in 20 words. What do you see? Okay? You see strip of gray, and then you see something round, black. Okay? Describe it like that. And then, in the next step, we will interpret it, okay? Just to make it easier for you. But I want you to describe this black and whiteness, okay? You have 2 minutes. Yeah, ribs, muscles. Musculus pectoralis major. Very good. Okay, cool. I like that one. Can you please take a photo of okay, cool? Hyperechoic lines, black with 3 parallel lines, very good. Muscle at the top, grayish, ooh, that's what I like. Can you take a photo of that? 2 ribs at the side, now it went. Black, shadow of the ribs, good. Muscle at the top, 2 ribs at the side, black. Ribs, intercostal muscle, pleural lung, oh yeah, it's this. Yeah. Hyperechoic, chest muscles, rib, pleural space, black and yellow. Black and yellow. Anybody farbenblind here? Dermal structures and musculature. Several artifact lines in different shades. 2 black shadows on the ribs. Very good. Anechogenic. That was also there. Adonis. Rib cage, muscle on top, hyperechogenic, dark background, yellow lung, okay. Black and yellow, okay. Sweet and sour, ribs and muscle, okay, good. Why I push you is because ultrasound as a technology or ultrasound as radiologists are learning. They're not learning it, this is the rib, this is the pleura, this is like that. The beach and sea, sexy, make fit. Okay. I think we have to pause the scroll. Yeah. So, why I want to push you is that you understand that, like with EKG, one thing is to describe this black and whiteness, okay? And another thing is, and we will scroll next, how you then interpret this image. And interpretation, I mean, go away from hyperechogenic, anechogenic, and so forth. But here, interpret what you see. Rib, okay? So this one is probably more familiar to you. So how would you interpret this image that we got on your colleague, Mr. Fit? Normal, healthy pleural upper lung, good lung, no pneumo, okay. Ribs with little really intravertebral structures, wrong probe. Seashore sign. There's air, muscle fibers, rib, dermal layers, normal lung, area between 2 ribs, muscle, pleural lung, normal chest wall. Catherine, can you please write down seashore sign? Area between 2 ribs, normal chest wall, normal, pleural lines, good, no B lines, A lines. Yeah, normal befund, yeah, good, no B lines, ribs, muscle, not at all. I'm sexy and I know it. Can you please photo that one? Thorax with rib cage, no? Normal, reoccurring echo pleural looks good, normal. Okay. Human. Human. Yeah. Okay. Back to the image, please. Pathologically ripped. So, back to the image. Do we have the... no. To show it on? No, we cannot. Okay. So, what we want to get to is all this exercise in echogenic and anechogenic and so forth, yes, is hopefully no pointer. What's wrong? Does anybody know? Like this. Aha, okay. So, what is this structure here? Shout out. What would that be? What's that? Skin. Skin and subdermal tissue, yeah? What is this bulk here? This? Muscle. Which muscle? We were here. Which one? Pectoralis major. Agree. Yeah. Which structure is this? Which one? Exactly. Intercostalis. Interior and exterior. What is this structure here? Yeah, rib, or rather, if we would be a little bit cheeky, we could say one is rib and other is actually seems like chondroid cartilage. And how would you know? You understand cartilage? Yeah? I think one is rib and other is cartilage. Which one and why? What's that? Why? Yeah. Okay. Good point. I also agree left one is cartilage, but why? Because we actually through it you can see hyperechogenic pleural line. Yeah? Can you show us the pleural line? Yeah? And the other one is rib, because past the rib there is full acoustic shadow. Okay? So technically speaking, yes, these are two ribs, and just below is pleural line. Just below is pleural line, and this is a very important landmark, most important landmark of lung ultrasound. Okay? Because, now bear in mind, before you said some hyperechogenic lines. Well, how do you know that this hyperechogenic line is pleural line? Because it's moving. Okay. How else? How about if it's not moving? How do you don't know then?
Because behind it, there is nothing.
Yeah, okay.
We can see nothing.
Okay, yeah. Anything else? Yeah, okay. Makes sense. Well, actually, there is only one absolute. The pleural line is that which is just beneath the ribs. Okay? Because in pneumothorax, as we will see later, this line will be frozen, not moving, so how can you know? And then there might be other lines below, A lines, and how will you know? The only way you can know, by definition, is parietal and visceral pleura are just next below the ribs, okay? So this is the landmark. Ribs, or cartilage, with their acoustic shadow, more or less, and just below is pleural line, okay? And any other horizontal echogenic line below is not pleural line. It's some sort of artifact, okay? And this is very important to know so that we can interpret images later on. So what I wanted to highlight here is black and white. When you are describing the ultrasound picture, you may say, this is black, anechogenic, echogenic, hyperechogenic, so forth. But that description is not automatic description of interpretation. This is the rib, this is the shadow. Or rather, because people assume that something is round and black, that would be a rib, they can make mistakes. So I want you to be very cognizant so that you are aware that not every black is fluid, not every white is pleura, and so forth, okay? Just to show you how radiologists, who are the ultimate masters of that in the details, how they are also taught and how they think. Okay, let's move on. So this is basic, where did I put it? This is the basic interpretation of lung ultrasound across intercostal space. Where did I put the, sorry, I lost it? Oh, sorry. Okay. Next. No? Okay. You know what these are? Hieroglyphs. Egyptian writing. How could you read and write in their alphabet? No, because you don't know the code, right? Yeah. So the story goes that up until mid-90s, even late 90s, people were completely ignoring lungs and lung ultrasound because they didn't understand the code. Cardiologists were looking at heart since 2000 BC, almost. Not really, but 50 years. Pneumologists, they were looking at pleural effusion since 50 years, okay? But no one really knew how to interpret the lung ultrasound and pathology because they didn't understand the code. And the code is that unlike with other ultrasound in the heart, where you see actual image, that's gray and black and white, in lung ultrasound, you actually have to understand patterns of artifacts. And once this is clear, then many things, like in hieroglyphs, become totally clear and logical. Before we go onwards, I would also very much like you to understand one single physical graph. And that is everything what we're talking about regarding pathology in lung ultrasound is actually some sort of interplay, is some sort of game, some sort of ratio between between air and water. You know how water looks like on ultrasound? How does it look? It's completely anechogenic, right? Ultrasound goes through. So on the ultrasound screen, it looks like black, agree? So can you interpret this image here? What would that be? This one here, below, that one. This blackness. Blackness above the diaphragm. How would you say? What is that? Say it. Pleural effusion. I mean this one. Look, this is liver, This is diaphragm. And what is this black? Above the diaphragm. It is pleural effusion. It is fluidothorax. Okay? So the ratio of air to water, air is 0, water is 1, so the ratio is 0, right? So it is on this side of the graph. But if we put the probe up in the air, can you put the probe up in the air, linear probe? Yeah. Put the gel on. Gel, put it on. Can we have the screen, please? Okay, and put it up like a torch. Yeah, unfreeze. Where is this ultrasound probe looking towards? What is it seeing? Air, agree? How does air look on the ultrasound image? It's just one harmonics of horizontal lines. You agree? The first one up here, only this. Where's the pointer? Pointer? No? Yeah. No. Yeah. Okay, so only this. Look, this is the gel. And this is the gel-air interface, this hyperechogenic line. And all the other horizontal lines are actually reverberation artifacts. Yeah? How are they called, these reverberation artifacts? How are they called when they appear in the lung? How are they called? A, B, C, D, Z lines. Which one? A lines. You see? So physically, regarding physics of ultrasound, A lines in his chest or A lines of air in Graz is the same. Okay? And here, back to the screen. Here, air is 1, right? And there is no water, so ratio is infinite. You understand? So that's why air in Graz or air in lung physically appears up here. And any pathology in lung is actually just ratio between air and water. Does that make sense? So if it is only water, that means fluidothorax. Pleural effusion, it's down here. If it's only air, it's up there. And where do you think would be pneumonia, lobar pneumonia? What is lobar pneumonia physically? Is it more air or is it more water? What do you think? More water, right? It's just full of edema. All the alveoli are flooded with inflammation. And this is why pneumonia on this graph is here, because it's more or less water. Just a little bit of air trapped in the air bronchogram. Okay? And if we go further down, where would be, let's say, where would be interstitial edema of lung? Is this more water or more air? Or something in between? What would you say? Before, in pneumonia, all the alveoli were full of water. In interstitial edema, only interstitium is full of water. What would be the ratio? Where would interstitial edema go? Would it go down here or would it go up there? Up there. You agree? I think interstitial edema would be somewhere here. 50-50. Little bit water, little bit air. Okay. Now, based on this basic physics, there are certain key pathologic findings of lung ultrasound. That would be like an alphabet or hieroglyphic alphabet of lung ultrasound. And one is if you have normal lung or if you have pneumothorax. Other is if you have totally water, which is fluidothorax. Then one would be consolidation, where there is water inside or the lung is squeezed, but not much air. And another pattern is interstitial syndrome, which is edema of interstitium. This meaning that interstitium is thick with water, but inside alveoli is still some air, so something in between. And that can be in pulmonary edema, interstitial pulmonary edema, or interstitial pneumonia, or actually it can also be one good whack with lung contusion. It will also arise edema, and it will be seen very similarly as interstitial syndrome. So please remember, next to the fifth one, which is normal finding, these are 4 basic pathologic patterns of all the different diseases of lung or in pleural cavity. Okay, now I want you, as I said, I really want you to understand. Now, you have already seen that image, right? That image. Please write down briefly what would be sonographic pattern of pneumothorax. What lines, moving or not moving, what do we expect? Barcode sign, design, non-moving pleura, barcode sign, not moving, abscess and flux sliding, no pleural movement, barcode sign. It really seems like you like this barcode, no? Hyperechogenic white, A lines. Yeah. Okay, makes sense. Anyone else? No moving, barcode sign. Barcode, seashore sign, barcode, pattern, pleural line, not moving. Yeah. Okay, very good. Hyperechogenic white. Okay, we get the point. Okay, is this similar to his intercostal space? Little bit similar. Do we see lung sliding? Can we see lung sliding? I think it was sliding back and forth here, right? Okay. How about this? Do we see sliding? Yes or no? Who says yes? Who says no? Okay, there is no sliding. Now tell me, which one is pleural line? Which one was supposed to slide? Which one? This one? This one? This one? Or this one? A, B, C, D. A, how many hands? B. Okay. C. D. Okay. A or B. How can you know? Exactly. Only with the ribs. This was the trick. I put the probe inside the intercostal space, not perpendicular to intercostal space. You understand what I mean? So in it, there is no sliding, but we cannot be sure which one of these lines, hyperechogenic lines, should be moving. So that's why you always have to start with the classical, this is called by Dr. Lichtenstein, bat sign. You also heard that, right? Did you hear about the bat sign? No? Okay. So this colorful gentleman thought that here was living a bat with his wings, okay? And just below is the pleural line. Okay, back to pneumothorax. Does this patient most probably have pneumothorax? Sonographically, yes. He would have intercostal space with pleura without movement. And on top of that, because this is pure air in the thorax, he would have to have, this patient also has reverberation artifacts. So I would say this one here is one A line. You agree with that? Yeah? This is the distance between subcostal tissue, the dermis and the pleural line, and same distance down to the A line. On top of that, what you can also see is that image also shows mirror artifact, because this is linear probe, high fidelity, high frequency probe, which actually shows all the structures down to the pleural line and then mirror across the pleural line. Because pleura, in this case this one, is very hyper-reflective of our ultrasound, right? What is hyper-reflective? That the ultrasound goes through the muscles, and comes to pleura, boom, and there is nowhere for him to go because he cannot go into air. So all this ultrasound comes back. That's why it is so white. But if I also showed you ribs, then you would be 1000% sure this is pleural line, and there is no pleural sliding, no lung sliding. Yes? So correct, your answers were correct. Patient with pneumothorax would have A profile, that means A lines, and pleural line is not moving. Good? One more thing. Where would we have to put the probe to identify pneumothorax? Here, A, B, C. A, B, C. If I'm lying down. If I'm lying down, show us A, B, C. Very good. A, B, C. Which one? Hands up for A. Hands up for B. Hands up for C. Yes. Pneumothorax is air. If he lays down, where do we expect the air to go? Gravitationally, most upper parts. Agree? So we expect air here. But if he is a young boy, like patient that I had, and I made enough mistakes, young boy, he comes with me with pleural pain, some dyspnea, and he had spontaneous pneumothorax before. So what's most likely diagnosis? Spontaneous pneumothorax. It doesn't take a scientist, no. I'm not a scientist. So even I could figure that out. But you know what? I put the probe here, and I saw lung sliding. And I thought, he doesn't have pneumothorax. And then we, of course, did X-ray, and so, oops, there is clearly a pneumothorax. What went wrong? Well, his pneumothorax went up here, because lungs, actually, apicus, are here. Okay? So be very cognizant. Ultrasound, unlike CT or Röntgen, you create your own images. And if you put the position wrong, your interpretation will be wrong. Okay? One thing to think. Okay. And if he has pneumothorax, if he's supine, can you lay down? And when he breathes in, if the lung is not totally collapsed, what do you think will happen? This lung will expand a bit, right? And if we are with the probe here, with breathing in, a new pattern will appear. What's that? What is pattern here? You see something moving here, up to here, but no movement here. What's that? What's that? What's that?
Lung point.
Exactly. Lung point. What is lung point? It's the edge of pneumothorax. What is the usefulness of lung point? It is absolutely specific for pneumothorax. Okay? So lack of lung sliding is sensitive. You have to have it. But that you prove it, pneumothorax, you have to show me lung point. But there is one caveat. If a pneumothorax is so big that all the lungs are completely collapsed, there is nowhere that lung will actually touch the wall. Will there be lung point? No. That's why sensitivity of lung point is low, but this pneumothorax will be very big, probably tension pneumothorax. So what that means is that in such a big pneumothorax, we will not see lung sliding, but we will also not see lung point, which is specific, but patient will be dyspneic, and most probably we will hear less breath sounds on right side. Okay? What will you do? What do you have to do? Forget ultrasound. This is the method that Hippocrates knew 2,500 years ago. Patient, what's that? Chest tube? Or, as a first aid, just a cannula, okay? Any cannula, IV cannula, poof, to release the tension. But of course then, for suction of for pneumothorax, you need a chest tube, chest drain, okay? And beware, people in severe respiratory distress, they will not lie down like our model or like that patient and show you lung sliding because they're too agitated. They cannot even lie down, okay? So their ultrasound will be useless. So what I'm trying to say is that you want to be doctors first, understanding classical medicine, and on top of that, in circumstances, many circumstances, you can also use your new little animal, and that's all I can say. Good? Lung point, very good. And in M mode and barcode, this is what I see was your pet peeve. This is normal pattern in M mode. It is called seashore sign. You heard of that? Dr. Lichtenstein, he had this association that this is the sea in Normandy, sea, and this is the beach. And he said, the beach sign, okay? But in pneumothorax, that's normal. But in pneumothorax, we see only that, barcode sign, or stratosphere sign, he said, all right? So in this image, what we actually see is the lung point. Here, exactly here, in this second, no lung was coming to this position, right? There was no lung. And then the patient breathed in, and then some lung appeared. And this is this part here. Okay? And if the strip was long enough, then he would exhale, the lung would move back, and again, we will see this. Why is this useful? Because it's quite impractical to sticky the movie file or USB stick. Here is the proof of lung point. I'm just kidding, right? In the paper history. But you can print out simple image of lung point, which proves there was pneumothorax. But where was this pneumothorax? How big was? Can you say that from this image? Can you tell? No, because this lung point might be here, or might be here, or might be here. And the lung and the pneumothorax was so big, or so big, or so big. Okay? It tells you nothing about the patient. It just tells you the fact there was lung coming in, going out, in, out. Okay? So you have to be, again, doctors first and sonographers second. Let's go to Menti.
Where
did we stay? Next, what conditions can cause absence of lung sliding? Is it pneumothorax? Is it anything else? Think about it, put it up. So, lung sliding, as we said, it's normal. But if there is no lung sliding, what could be cause for that? Absence of lung? True. That would probably be due to pleurodesis. Yeah, completely true. And unless you ask the patients, oh yeah, I had pleural tomy, then you think, aha, pneumothorax, boom, drain. There's nothing to drain. Absolutely, excellent point. Pleuritis, okay. Trauma, okay. Pneumothorax, emphysema, good one. Pneumothorax, hemothorax, pleural, death. Edema, hemothorax, perspiration hold, very good. Fibrosis, very good. Adhesions, very good. Lung compression, oh, you know everything. Why am I here? Well, exactly. These are all causes for absence of lung sliding. If I hold my breath, will there be sliding? No, because there's no ventilation. If anesthesiologist is not bagging the patient, is there a pneumothorax? You cannot really know, because there will be no lung sliding. As you said, adhesions, pleurodesis. Yes, lack of lung, pneumothorax. Remember, if they intubate into the right bronchus, what will be the pattern of sliding in the left side of the chest? So they'll be sliding here, but not sliding here. Make sense? It's one of the methods how we can confirm bilateral ventilation that we see after intubation. We see sliding on this side and on this side. So all of this is absolutely correct. I will share the Menti with you where you can see all the answers. Very good. And how will you know? Again, you will come from certain clinical context. You will ask history. Okay, you are dyspneic today. What are your past medical history? Ta, 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 ta. Aha! So maybe that's why you have severe pulmonary fibrosis. That's why we don't expect it there. Or adhesions. Very good. Next pattern. We have a few more minutes. Okay. So you saw A lines, horizontal lines, and we saw pleural sliding. What would be this pattern? I think it's clear it's pleural effusion, right? Do we know how to interpret this image? So there is certain hyperechogenic line, diaphragm, here is probably liver, and what is black, which is then in thorax, right? Because this is cranial. This is cranium, and this is ass. So this is thorax, right? What is it? It's black in the thorax. It's fluid in the thorax. Simple as that, right? Is it transudate? Is it exudate? Is it blood? How will you know? Can you know with ultrasound? Theoretically, you can know if there is certain, like you will see in this case, certain like a cornflakes, like muesli a little bit. What would that be? Is this transudate or exudate? Logically, exudate. Because I don't think cornflakes can come through 10 nanometer pores, right? That if it's completely clear, then it's probably transudate, although it can be exudate as well. But if there's something inside, that must be exudate. So you go into separate table, causes of exudate, okay? And then again, if we are in Graz, probably pneumonia, malignancy is top, but tuberculosis is further down, right? But if we are in South African Republic, then tuberculosis probably up, More likely, you understand? So again, you start with your history and your demographics, and then you can make sense. Because in there, in black and white, it won't say TB. It does not say TB. It is just black and white. Machine is completely stupid. Okay, on the Röntgen, can you tell which one is pleural effusion, which one is consolidation because of atelectasis or because of pneumonia? How does one look to the other? Where would you say, where is pneumonia? Left or right? To be honest, I have no idea. I never had any idea. And I don't have to have any idea because I simply look with ultrasound. Maybe this looks like severe pneumonia. I don't know. You take a probe and you see it's all black. What was that? What was that? Effusion or pneumonia? Effusion, pleural effusion. And here, this is consolidation. Yeah? With, what are these white specks inside? What is this? Yeah, shut it, put it out. What's that? Trapped air. Where would air be trapped in pneumonia tissue? How is this called pathophysiologically? Yeah, you're completely correct. But where is air trapped? Mostly, and such a big chunks of air. This is air bronchogram. You heard about air bronchogram in Röntgen? Yeah, you will, upper levels you will. Now you can see this white, hyperreflective, is air trapped in the bronchi. And it's quite specific for pneumonia. Okay, this is how pneumonia looks like. Okay, I will tell you a little story. When I was third year, and I was studying for pathology, third year here, can you tell me, or no, fourth year, you just started. Can you tell me the stages of pneumonia? Stages of pneumonia. Huh? Was that Exactly. It's called hepatization rubra, red hepatization, hepatization grisea, how you call it, gray hepatization, and resolution. But the hashtag is hepatization. And now remember what you saw in previous lecture, how do liver look? And now remember, look how this looks. Does this not look a little bit like liver? Yeah. That's why these pathologists were completely right 200 years ago. They already knew before ultrasound. Okay? Okay, same. Where would you puncture? I think you want to make sure that you know where you puncture. You don't want to puncture lobar pneumonia, but just a fusion, right? Okay, regarding pneumonias, they can come roughly in two flavors, either interstitial pneumonia or lobar pneumonia. Interstitial pneumonia is a little bit interstitiumistic, and this is here, or nice chunky lobar pneumonia, look like a rose, concentric air bronchogram. You see these white specks? This is air bronchogram. Okay, so lobar pneumonia in the right. This patient, your age, he came in coughing, some fever. I listened to him, and there were crackles here. I put the probe on, and I see something that is obviously not A-lines. Agree? And this is what it was. It was interstitial pneumonia, you see, thickened pleura, and a little bit also here, you can actually see some subpleural consolidation. So this pleura was being infected. It produced B-lines because of interstitial edema, but it was also progressing, and there was already a little bit of subpleural consolidation. We gave him antibiotics, so we don't know how he would go without, but he didn't come back, so I presume he's okay. Probably he would be okay even without antibiotic, but that's another story. Okay, so that was interstitial pattern. Can you know if this is pneumonia or contusion or fibrosis? To be honest, at sonographic level, you have to be very much pro, okay? Because they look very similar. But you don't have to be pro radiological, okay? You don't have to be all radiologist, because you know the clinic and differential diagnosis first. And differential diagnosis, the most likely cause was pneumonia. And without X-ray, in 20 seconds, we could prove what he has, the disease. And he went home after 2 minutes. Okay, huge fluidothorax. You see all this black C, and inside is the lobe with some air bronchogram, pneumonia, or even perhaps beginning of atelectasis to start with. Look at that trick. What is this structure here? This one here. This one here. What do you think? That was actually spleen. Okay? That was spleen. This line here is diaphragm. Yeah? So this is abdomen, this is thorax. So this is above diaphragm, all this structure. What is that? What would that be? Are these A lines? Horizontal lines? No. Are these B lines? No. It's consolidation. Yeah? And you can see that this consolidation ends abruptly with, again, some white flecks. And this is air bronchogram. So this is lobar pneumonia, right? All the alveoli are flooded with water. And this thing here is edge of pneumonia. Okay? So this is lower left lobus. Yeah? And I think it's clear it takes 10 seconds to know. You see all these specks inside here? That's air bronchogram. Again, consolidation, pneumonia, air bronchogram. Two more types. One is atelectasis. Atelectasis physiologically is something where the lung either gets squeezed and it squeezes the air out, or the bronchus is blocked and the air gets absorbed. Either way, it doesn't have bronchogram. And as you see, there is a lot of fluid around it, diaphragm, and this is atelectatic, probably left lung. How do I know it's left lung? Because pay attention. You see this hose here, and it was pulsating. What was that? It was actually thoracic aorta. And the ultimate proof that all these organs are nicely packed, vacuum packed like peanuts, they're packed in. So if something arises, water arises, then something else has to be squeezed out. And that's atelectasis. And because ultrasound travels perfectly through water and through consolidated lung, ultrasound could show us descending thoracic aorta. How cool is that? Except it's not cool that the lady had a whole left lung full of water. One more thing, Austrian colleague from Tyrol, he also found out that pulmonary infarctions with pulmonary embolism, they produce very little small anechogenic atelectasis. But in this case, you really have to go in each intercostal space, scanning and trying to find such pulmonary infarction, just to show you. Otherwise, you cannot really see pulmonary embolism. Okay, one thing, if we have enough time, is interstitial syndrome. So we spoke about pneumothorax, that is full of air, right? So in that graph, it was left up. We spoke about fluidothorax and pneumonia, which is total water. And in between is interstitial syndrome. And here, the trick is that this is normal alveolus. Agree? It's pretty much mostly only air. And that's why this interface physically gives A-line, A-lines. But if this interstitium is edematous, okay, because of inflammation or because of edema, cardiogenic edema, increased pressures, then this tissue physically behaves differently. And it produces such vertical artifacts, which are actually also little lines, but these are called B lines. Okay? You understand what I mean? So these B lines are sign of interstitial disease. Either pulmonary edema, cardiogenic pulmonary edema, or RDS, or fibrosis, or chemical pneumonitis, and so forth. So A lines and B lines. And one thing also that you have to understand, also our colleague, our model, he surely had one small little artifact. This would be called a little b. But he definitely didn't have such pattern like that. You agree? And this would be proper B lines, like that. He didn't have that, of course, because clinically he looks quite okay and eupnoic. Plus, he's not the right type of patient for pulmonary edema. So, and these B lines are sometimes also called lung rockets, and these B lines have, technically speaking, now 5 characteristics. They have to arise from pleura. They have to move with respiration, which makes sense. They have to be sharp. They have to eradicate A lines. And they have to go all the way to the bottom of the screen. Okay? And these are definition of B lines. And this then is the pattern that we will see in pulmonary edema. And if we have 3 or more, so 1, 2, 3, 4, in one intercostal space, it's called interstitial syndrome. But interstitial syndrome at that location of probe, okay? So you can have small interstitial pneumonia locally, but cardiogenic pulmonary edema usually is diffuse because it's pressure problem. Agree with that? Sometimes they're also called lung rockets. I'm not exactly sure why Liechtenstein called them that, but okay, anyhow, lung rocket. So, as we said, Röntgen, chest X-ray, is like summary view through the chest. But lung ultrasound is localized view in each position that we view, okay, like auscultation. Something here, something here, something here. So to make sense, you have to really put the whole geographic pattern together. And in cardiogenic pulmonary edema, because this is increased venous and capillary pressure, we expect diffuse increased pressure and diffused interstitial syndrome. You agree with that? So we will expect diffuse B lines here and here and here and here and everywhere. But with localized pneumonia, which is not RDS yet, we expect only here or here. Okay? Where we have crepitations, there we also expect the B lines. And just to sort of prove it, they did absolutely most fantastic, sexy study ever. What they did is there is certain disease, lung proteinosis, that you treat so that you submerge, you lavage whole lungs. There are little proteins in alveoli. They make the restrictive lung disease. And the way you treat it, if you selectively intubate one and the other, and then you lavage, okay? And then, of course, they looked through the submersion when the lung was becoming submerged and cleared out. They looked sonographic pattern. So what would be logically, what would be initial pattern? A lines, B lines, consolidation, before they started submerging. What do you expect? What? A lines and lung sliding like with him. You agree? And this is actually what it was, except they also had little bit, remember this is chronic disease, also little bit inflammation. So these patients had occasional B line. Then they put in water. What happened? Some more B lines because that was beginning of edema. Then there was complete submersion with little bit of air trapped inside, like air bronchogram. Then this was complete submersion, and then they sucked the water out. We see some leftover of wet lungs, and in the end, voila, A lines. Isn't that beautiful? So that was one lung, and then they intubated the other lung and did the same thing again. How much time do we have? Theoretically, none. Okay. Just a second. Okay. Okay. Another beautiful study I want to show you, not for the sake of studies, but for the sake of how smart people are. And this lady, Dr. Noble, she's really, really pioneer of lung ultrasound. And what she realized is that we could also monitor this concept of lung being wet, being full of water, with hemodialysis patients. Because what happens, these patients, just before hemodialysis, chronic hemodialysis, they are volume overloaded, right? Because their kidneys are not working. So they are volume overloaded, so this fluid also goes little bit to their lungs. They don't feel it like pulmonary edema, it's subclinical. But definitely they have some. And during the dialysis, they also did the lung ultrasound, seeing how much this lung water is being sucked out. And look at this beautiful graph. They came with many B lines, black, and went with gray. And most importantly, look, during the dialysis session, 3-4 hours, they all came with most percentage of B lines, meaning their lungs were wet. They had some interstitial edema, okay? And as the dialysis was working, their volume was being equilibrated. They lost 3-4 liters of fluid. Their comet tail signs, their B lines went down. And they, of course, felt better. They could probably also subjectively feel better and breathe better. But most importantly, physiologically, their lungs dried out. Now imagine what happens if they would miss this dialysis. They would go from subclinical pulmonary edema, next day probably into overt clinical pulmonary edema. Okay? Good.
cases we went through, so we don't have to belabor with that. So in the end, I think we're almost finished. Now, this. I have one more last Menti for you. Oops, sorry. Please take out your devices for last time. And reflect, think about the summary for yourself. What did you learn? Also put it up so that I can follow up and reply you in the email what you didn't understand. What the? Okay. Okay. Anything more specific? Okay, good. Pleura has to be directly under the ribs. I agree with that. How many diseases one can diagnose? Quite a few. Basic lungs, thanks. Thank you for the service. You're welcome. A line, B line, Bericon seashore, different types of line causes. Pathological key patterns, it's about ratio between water and air, very smart. Different types of that, Okay, so coming back to these two tables. Can we see pneumothorax with lung ultrasound? Can we see hemothorax? How do we see it? How is it? Anechogenic, hyperechogenic, A lines, B lines? It's black, no? It's black. Can we clearly distinguish hematothorax from non-hematothorax? No, unless we see coagulated blood, but that takes some time. Myocardial infarction, can we see that on lung ultrasound? If myocardial infarction produces pulmonary edema, then indirectly yes. But we don't know if it's because of myocardial infarction, right? So we need EKG and echo. Pleural effusion, can we see? Emphysema, can we see? Not really, but over one big emphysematous bulle, we would see lack of lung sliding, similar to pneumothorax, okay? But definitely in COPD exacerbation patients, do we expect A lines or do we expect B lines? What is the problem with COPD exacerbation? What's the problem? Is the problem there's too much water or there is actually too much air? Too much air, they cannot exhale. They have no problem with water. So that's why they are hyperinflated and A lines and lung sliding. So you can die of COPD exacerbation with perfectly excellent lung pattern like his. Okay? So that's why you still need stethoscope. Emphysema, okay. Pericardial tamponade, yes, we can see, but that's in the echocardiographic heart, right? Aspiration, can we see that with lung ultrasound? I would say if it produces chemical pneumonitis, then yes. But otherwise, whatever is here up in trachea, you cannot see. Lung emboli or pulmonary embolism. This is the only case that I wanted to show you, but we will discuss here. Can you see that on lung ultrasound? What do you think? What is massive pulmonary or pulmonary embolism? Which system is problematic? Is this lung fault or is this cardiovascular system fault? Exactly, lung embolism, pulmonary embolism, basically has nothing to do with pulmo. It has to do with vessels to the pulmo. So what pattern do we expect with someone with even massive pulmonary embolism? What pattern? Will there be sliding? Yes. Will there be A lines, B lines? A lines, yeah. Again, he can die with sonographically completely perfect pattern like his, right? But how will we know? Sonographically, how can we identify massive pulmonary embolism? With heart ultrasound, yeah? We will have acute cor pulmonale, and don't forget, DVT already had, deep venous thrombosis. We can identify thrombosis that went up and become embolus. Make sense? So remember, pulmonary embolism is a tricky disease because auscultation-wise, lungs are okay. Sonographic, lungs are okay. Because this is not lung problem. It's circulatory problem. Subglottic edema, you cannot see. Why? Because even if we looked up in the trachea, once there is air as it's inside the trachea, you cannot see. So whatever is hidden, no. And bolus, if it's supraglottic, you cannot see. If it's subglottic, again, if it's somewhere inside, it will be lost in the air of trachea. It will be just A lines, so you cannot see. Okay, any burning questions? No? If not, I thank you very much for your energy and sticking with me. And I wish you all the best. Goodbye.
Thank you for your lecture.
Ja, danke
A warm
schön.
welcome. Bitte gerne.
Thank you very much.
So before it's you to get active again, some short information. The nice drawings from yesterday from Professor Feigl, they are on our Facebook homepage. There's a link. You can download the drawings there. What is also important, especially for tomorrow, bring your white coat. Even if you have 2 at home, bring 2. We need every white coat we can have. And what is also very important, the social evening. Today is in the office pub in the Trautmannsdorfgasse 3 in Graz. It will start at 6 p.m. We all are looking forward to this event, and we hope we see all of you there. And yeah, we now have a quick break, about 5 minutes, before the next hands-on session starts.